And that's what we are going to discuss in the coming few minutes. So, in everyday practice, we are facing two types of glaucoma patients. Either a glaucoma patient who is coming for follow-up, he is a known glaucoma patient and he's well diagnosed and he's on treatment, or another patient who is just coming for consultation, just for refraction or something, and or red eye or something, and he doesn't know that he has glaucoma. So for a new patient assessment, we are talking about a patient who doesn't know that he's glaucomatous. We have to perform clinical evaluation. We have to identify the risk factors for his glaucoma and for the glaucoma progression in this patient. We have to classify his glaucoma, either primary or secondary, open angle or angle closure. We have to identify the stage of the disease, the treatment decision, and follow-up schedule for the patient. Regarding the patient who is already known glaucoma patient, you have to test for any clinical change from the previous visit, and you have to adjust your treatment according to the clinical finding or clinical change and plan for the follow-up. Here are general recommendations that are given for a clinical evaluation for a newly discovered glaucoma patient: patient age, systemic disease, concomitant medications like steroids for rheumatoid or for MS, whatever, that may impact or may have an impact on his glaucoma, ocular characteristics, the clinical presentation, we'll discuss later, and concomitant eye disease. This patient has uveitis, cataract, retinal condition, age-related macular degeneration, whatever. And patient's expectations and fears. You have to correct his mistaken beliefs, and you have to assure him that as long as he's going to follow up with you and he's going to listen to your instructions, he will never get blind, inshallah. So, regarding the clinical evaluation, we are all taking the visual acuity and recording the refractive error, anterior segment evaluation, starting from the cornea, corneal disease, endothelial, pigmentations, pupillary action, anterior chamber, whatever. Intraocular pressure, which is the one which we can depend on, is the Goldman applanation tonometer. Do not depend on the air puff tonometer, do not depend on Perkins tonometer, do not depend on tonopen. So this is the one registered. That's what we can plan our next steps or our medication on, or our mode of management on. Posterior pole evaluation, including the optic nerve head and the retinal nerve fiber layer by slit lamp by microscopy, and visual field and structural assessment. Assess for the risk factors for the glaucoma, and these are the only risk factors listed here that for the presence of the glaucoma and not for the glaucoma progression. Of course, there are some other risk factors that can be discussed, but they are less documented in literature. Of course, we have to record the intraocular pressure, age of the patient, family history of glaucoma, race, and myopia. Okay, so this is a glaucoma patient, or suspecting that this patient is glaucomatous, and we want to classify him. As you can see in this scheme, I want you all to put in your mind this scheme while you are handling a glaucoma patient. We have a vertical blue line and a horizontal red line. This vertical blue line is the one that is differentiating the open angle from the angle closure glaucoma, and this blue line, or this horizontal red line, is the one that is differentiating patient presenting to you with glaucomatous changes in the upper part of the line, and without glaucomatous changes in the upper part of the line, and with glaucomatous changes under the line. I just want to say a few words about a glaucoma suspect and ocular hypertension, because sometimes it's we cannot reach this patient is ocular hypertensive, or he is a glaucoma suspect, or he is a glaucoma already. So this horizontal, as we said, a glaucoma suspect patient, he's an individual with one or more clinical findings and a group of risk factors, at least in one eye, with gonioscopically proven angle to be opened, leading to an increased likelihood of developing primary open angle glaucoma, regardless of the level of the intraocular pressure. So he is a patient, normal patient. He has one finding, for example, large cup, or some differences in the vasculature of the optic nerve. So you are suspecting that this patient, even in one eye, you are suspecting that this patient is, maybe he is glaucomatous, maybe not. And while you are interviewing the history with the patient, he was telling you that my father is glaucomatous, and so you are putting him in the group of the glaucoma suspect patient. Regarding the ocular hypertension, it is defined as a consistently elevated intraocular pressure above the average, which is 21 millimeter mercury, associated with normal appearance of the optic nerve and the retinal nerve fiber layer, with normal visual field tests and an open angle, of course, by gonioscopy. So now we have a clear definition of a glaucoma suspect and ocular hypertension. What about staging of the disease? Now, we did the clinical assessment of the patient, vision, age, gonioscopy, retinal nerve fiber layer, and then we move to the second step. This patient is glaucomatous, and we need to put stage of this patient. How can we stage him? There are several classifications for staging of the disease. The most used classification is that one done by Hodap and Parrish, and its modified version by Mills, taking in account the mean deviation. So, for any visual field that you will be doing for any patient, you have to look first to the mean deviation of this patient. We have two machines that we can use, either Humphrey or Octopus machine, and their staging, they are nearly the same. With the Humphrey staging for the mean deviation, starting from 0, there is no glaucoma or ocular hypertension, to stage 5, which is the end stage of glaucoma. And with the Octopus classification, it also starts from 0 till 5, where it is the end stage glaucoma. Okay, let's do some exercise. This is a visual field of a patient. She's 77 years old, and she was referred to us in the year of 2001 with severe visual field defects in both eyes. Actually, this case is a good example of concordance between the function and the structure, because we will see later that some patients do not always go like that. She's myopic, minus 14 diopters in the right eye, and minus 11 diopter in her left eye. The maximum non-treated intraocular pressure, non-treated, was 24 millimeter mercury on her right eye, 25 millimeter in her left eye. Central corneal thickness was average, 525 and 530, and the iridocorneal angles were open with no pigments, so do not suspect pigment dispersion syndrome. She underwent a trabeculectomy with mitomycin C in both eyes in the year of 2002, and her IOP went down to 11 millimeter mercury in both eyes. 2 years later, a prostaglandin was added in the evening to maintain this low pressure. Her pressure till 2014 was between 10 and 12 millimeter mercury. The visual field did not change, and they did not deteriorate during her follow-up. That was her optic disc, and I want you to concentrate on the vasculature, especially on her right eye, your left-hand side. I want you to look to the superior temporal vein and its angulation. I will try to superior temporal vein here. I want you to see, no, I want you to concentrate on the angulation here and also this small vessel here. The neuroretinal rim thinning is more visible in the right eye inferiorly here at this area and superiorly here. And for the left eye, there is a thinning which is mainly seen in the inferior rim. Look at the angulation here, and there is also slight angulation in this area. That was her optic disc. So that, what you will see in the clinical assessment by your own eye with the 78 diopters on the slit lamp, and that was her OCT. This OCT, this group of OCT, it was done starting from the year of 2011. I'm bringing now, of course, there are several OCT. This is a time domain OCT, spectral domain OCT. Before, in the year of 2001, we were only having the time domain OCT. I brought this one especially to see that from the year of 2011, the OCT done in 2011, 12, 13, and 14, it did not show any progression. So the OCT layout did not show any progression, as well as during a shorter period, within 4 years, and that's it. That's for the patient. What about other patients? And I think most of you have faced some cases that the clinical finding do not go hand in hand with the investigative or the structural finding and the functional finding. You can see this patient, this case is given as an example of what I said before, when the clinical and the structural findings do not go hand in hand. She's 76 years old woman. She is a well-known glaucoma patient. The mean deviation in the visual field was only 5.6. I don't know. Yes, it's obvious here. It's 5.6 here. And this corresponds to an early stage of glaucoma. So if we only take in consideration the mean deviation in the classification of Hodop and Parrish, we would have said that this is a mild case of glaucoma. However, the optic nerve is much more damaged than it could be at an early stage of glaucoma. Considering the structure in addition to function is helpful in assessing the severity of the glaucoma. So that's her optic nerve. You can see here, you cannot see the vessel. This vessel should be passing like that. You cannot see it anymore. So you have a superior lost neuroretinal rim and very thin inferior neuroretinal rim. Regarding her OCT, you have only here, you have only thinning in the superior and slight thinning in the area between the superior and the nasal quadrant. Of course, also the temporal quadrant you have thinning in. So, for a new patient decision making, we have now done the clinical assessment. We classified the patient. We know the stage, in which stage the glaucoma this patient is present. He's in mild glaucoma, moderate or severe glaucoma. What next? Should we offer treatment to this patient? Yes, as a rule, if it is an established glaucoma or ocular hypertension with a high risk of developing glaucoma. But consider not to treat if the diagnosis is not clear. The ocular hypertension suggests low risk glaucoma suspect patient. Mild glaucoma in very old patient, although this should be discussed with other members of the family, and in primary angle closure glaucoma suspects. Before decision making, it is important to set treatment objectives. Consider the efficacy of the medication or the line of management that you will be offering. Consider the safety of your line of management and education of the patient. You have to put in your mind that the prescription is not the final step of the consultation for a glaucoma patient. Patient needs references for a better knowledge of the glaucoma and what is expected from the treatment. And I really advise all of you to have these flyers that is talking about the natural history of the disease, what will happen when you experience something like that, when to go to your doctor, how to be careful in putting your medication. Some of the patients, I'm talking about 50%, they are putting the eye drops wrongly, for example. So, the first choice treatment takes in consideration balance between the safety and efficacy. And this is the result of the recommendation of the EGS 2015. And according to these guidelines of the EGS, we should put two parameters in account, the patient and the drug. For the patient, you have to put in your mind his clinical presentation. Will this line of management that I will be offering affect his quality of life and the disease severity? On the other side, the drug features, you have to put in your mind the mechanism of action of this drug. Will it work in this type of glaucoma for this patient? The efficacy of the medication, and would the patient afford the cost of this medication or not? So this schedule, I think you are all familiar with. The prostaglandin analogs comes in the first line of for treatment, and it has a peak of decreasing the intraocular pressure of 33% and a trough of 28%. Then comes the beta receptor agonist, 27, and a trough of 26%, carbonic anhydrase inhibitors, with a peak of 20% reduction of the intraocular pressure and 17% as a trough, and selective adrenergic agonist with a 25% and 18%. Let's go back to our first patient. So, is this a glaucoma or not? Just raise your hand if you agree this is a glaucoma. Yes, because you just came. You did not attend from the beginning. We cannot judge right now. Okay. What about the clinical evaluation? We'll be discussing later. Treatment, follow-up, and do I need more information? Of course, now we still need more information. Actually, this is a male patient. He's 75 years plus, treated for glaucoma since the year of 2005. Maximum intraocular pressure was 20 millimeter mercury. He has a poor local tolerance for eye drops. Selective laser trabeculoplasty was done in the year of 2007, and he was referred to us in 2007 with open angles, pressure of 18 and 17 with an average pachymetry 550 and 560. That was his visual field. I want you to concentrate for his left eye on your right-hand side. I want you to concentrate on these 2 points. For his left eye, the glaucoma hemifield test is borderline. There are these three contiguous scotomas in the inferior field. And one of them, this dark one, it is statistically significant. Regarding the right eye, it seems and it looks normal. And that was his visual field in the year of 2007. Of course, in the year of 2007, we only have the time domain OCT, and it showed that he was having a decrease in the average retinal nerve fiber layer thickness in the right eye, 72, 68 in the left eye. So, since the patient did not tolerate the various medical treatments he has had before, we decided, and after his own consent and after his family consent, not to give him any medicine and to follow him up regularly every 6 months. And let's see what happened in the coming 6 months. That's a series of field of vision done from 2007 till the year of 2013. And as you can see, the visual field did not progress during a 5 years period. And of course, we are using, when you are assessing a visual field, we have 2 types of analysis, the trend and the event analysis. Event analysis, it's a visual field defect that is happening at once. One time, no defects, and this time you have a defect. Trend analysis, you are having a scotoma, and it's increasing on previous field defect. When you are doing a visual field, you are having the scotoma is increasing till performing another bigger scotoma. Actually, this patient has a stable visual field from the year of 2007 till 2013, and this go in line with the collaborative normal tension glaucoma study. This patient was having a non-progressive normal tension glaucoma. Remember that all of this period from 2007 till 2013, he did not receive any medication. And that was his optic disc photo and done with the OCT. Also, his disc did not change by using the guided progression analysis software. It did not show any progression, and the patient till up to date is being observed once a year and not treated. As we said before, this patient probably has a normal tension glaucoma that do not progress by time. Let's go to another case. This is a 49 years old male patient. He's just coming for refraction, and he's asymptomatic. He's not complaining of anything. His intraocular pressure was 36 millimeter mercury for his right eye, 22 for his left eye, and by slit lamp examination revealed Krockenberg spindles. I think you could be seeing here. Yes, here it is. And iris transillumination and angle with heavy pigmentation. So this is an example of pigment dispersion glaucoma. The patient has already functional and structural. I hope it will be appearing here, but he has a mean deviation of around 6 decibel. And I want you to, here in the infratemporal, here at this area, he has a thinning here. Hope you will be seeing well. So it's your side now. What mode of treatment you will be offering? Anyone suggest anything? Medical treatment, laser treatment, surgery? Okay, so regarding his age, he's only 36 years old. He's 49 years old with pressure of 36 millimeter mercury and starting structural changes in his right eye, so we can start medical treatment for him. But let me ask you, what about YAG laser? YAG laser, not selective laser trabeculoplasty. What about YAG laser peripheral iridotomy? You agree with me? Excuse me?
After we do gonioscopy for after we do gonioscopy for the patient,
Yes.
we can decide to do PI or not, looking to the angle.
No, I'm asking, is diag laser peripheral iridotomy, does it has a place in our patient here?
Yeah, it depends on the gonioscopy.
Depends on gonioscopy.
Yeah, if it's open
Yes,
angle
it's an
or
open
occlude.
angle. It's an open angle here. That's the Schwalbe's line, and that's the heavy pigmentation in the trabecular meshwork underneath the scleral spur, and you can even see some parts of the ciliary body here. So it's an open angle.
I think no need. This is my
Okay, okay. There was a study that was done for patients with pigmentary glaucoma. Why? What is the pathophysiology of this pigmentary glaucoma? The problem is the posterior bowing of the mid-periphery of the iris. There is a posterior bowing, so with the pupillary constriction and dilatation, there is some sort of friction with the anterior surface of the lens, resulting in liberation of the pigments that is blocking the trabecular meshwork. So if you do a PI, you can equalize the pressure on either side of the iris, and you can relieve this posterior bowing in the mid-periphery of the iris. So it's considered a line of management in addition to you cannot do it alone. It's in addition to your medication. You can try intraocular pressure lowering drugs. If he did not, there is no improvement, no lowering pressure, he did not reach your target pressure, you can try laser, selective laser trabeculoplasty. If no improvement, you can go on for surgery. Let's go now to a new patient follow-up schedule. You have to check the intraocular pressure 2 to 4 weeks after initiation of the therapy. You have to check if your target intraocular pressure is in range or it is reached or not. You have to assess the rate of progression. Functional testing should be carried out, like perimetry, 6 times, depending on the stage of the disease, and during the first 2 to 3 years, and structural assessment should be done by doing the OCT. If the rate of progression is unacceptable, a change of therapy is needed, and follow the patient more closely. Now, we are going to discuss how to deal with glaucoma patients already known as having glaucoma. The previous was a newly discovered one. This is a well-known glaucoma patient. We have to look for any clinical change that happened from the last visit, and I just discovered during this visit. You have to adjust your treatment and schedule for a follow-up. Check for symptoms and complain. Ask the patient about the tolerance of the medication. Is it causing any side effect like stinging sensation, redness, itching, whatever? Ask the patient about the compliance and adherence. Don't ever ask your patient, are you using your eye drops? No, don't ever. Because if you ask him, yes, I'm using. Did you put your drops today? Yes, I'm using. But always try to give your patient I like to call it a hidden questions. Hidden questions like, tell me what about your eye drops? What is the suitable time that you are using the drops? Is this time you are using permanently? You are using by 10 p.m., for example, every day by 10 p.m.? And you should try to correct any misbeliefs in the patient. Ask the patient about new systemic conditions like diabetes, hypertension, whatever, or medication, and then evaluate the patient on the slit lamp, evaluate for any anterior segment changes, measure the intraocular pressure, again Goldman, do gonioscopy, especially for phakic patients. Re-evaluate your treatment strategy. Measure the rate of progression. As we said, we have We can measure the rate of progression by a series of visual fields, and you can also measure the rate of progression by a series of OCT. There are special programs for that. Is the intraocular pressure at or below the target pressure? Tolerance, check for tolerance and safety of the treatment. Put non-adherence into your account, but do not blame the patient. Try to understand why he's not using his medication and explain and encourage the patient. Plan for the follow-up, next appointment, if you need him to go for consultation for retina, oculoplasty, whatever, other subspecialties in ophthalmology, and you have to record if you need to repeat the visual field next time or not, or doing OCT next time or not. Settle some new objectives like a new target pressure if you find your pressure is progressing, so you have to put a new target pressure, and check for other eye disease like cataract, age-related macular degeneration. This is the last case. She's a 60-year-old woman with low-tension glaucoma, diagnosed in 2006 and referred to us in 2008. She has a fast progressing glaucoma in her right eye with maximum tolerated medical therapy, and she's very afraid about surgery because of what she heard from her friends and associates. Trabeculectomy with mitomycin C was done in September 2011 for the right eye that was fast progressing, and the intraocular pressure dropped from 15 to 9 millimeter mercury. Actually, I want you to see her visual field index. That's what, when we started to follow up this patient in 2007, that was her visual field, which progressed in these 5 years to this around, she lost around 40% more than of her optic nerve function. Anyhow, this patient, she displayed dramatic progression on the visual field and in OCT as well. At one visit, it was possible to see these three, 1, 2, 3, these peripapillary hemorrhages. In the beginning, the patient, as we said, she refused the surgical interference, and after a long discussion, and when we showed her all of this, her visual field index and the photo or her disc photo, she agreed to do the surgery, where trabeculectomy with mitomycin C fortunately was done, and it was successful without any complications or additional maneuvers. That was her visual field index in 2012 and 2013. As you can see, it's stable here now. So bringing the hair pressure from 15 millimeter mercury to an average of 8 to 10 millimeter mercury without topical treatment after surgery, it halted the progression. The visual field, as you see, was stable, and the structure was stable as well. This optic disc, you cannot see anymore the flame-shaped or the hemorrhages, the peripapillary hemorrhage that was present on her disc, and even the OCT with the guided progression analysis software, it did not show any progression of her structural retinal nerve fiber layer. So, you have to consider the following. You have to get enough information from the visual field. You have to detect the progression, evaluate the rate of progression, identify fast progressors, adjust your target intraocular pressure, and inform and try to educate the patient and family about the disease. Avoid decisions based on single intraocular pressure measurement, visual field change without confirmation, structural change without confirmation with the same machine. Do not depend on OCT done in your hospital and another OCT done in another hospital. Structural imaging artifacts, and avoid making decisions without performing visual field tests. Again, avoid making decisions without performing at least visual field testing. So, to conclude, consider the patient as a whole, take the time to document clinical findings and take the time to document progression. Evaluate the benefit versus safety of medication when considering therapy, and regularly re-evaluate your strategy of management. Sorry if I have been too long, but actually it's a long lecture and I tried to simplify it as much as I can. Thank you.
So I wanted to spend a bit of time. There's a big change now in the field of glaucoma in terms of angle surgery. There's new procedures coming about. We've heard many, many different topics from Dr. Khaimi on canaloplasty, ab externo, ab interno. We've heard about the different, so how do we make sense of all of these changes in glaucoma? So I just wanted to give you a landscape overview of how this field is dramatically changing. Now, thinking for glaucoma, we're undergoing a renaissance, like cataract surgery from extra cap to clear corneas, small corneal incision cataract surgery, topical. So I think glaucoma is undergoing that revolution right now. So basically, the typical clinical practice about a few years ago was basically you start patients on eye drops, typically a prostaglandin analog or a beta blocker, or maybe a carbonic anhydrase inhibitor, and then you look for a drop about 20 to 40%. If further pressure lowering was needed, you subject them to laser trabeculoplasty, and if that doesn't work, you go to the extreme of a trabeculectomy or a tube shunt, and then finally a destructive procedure like a ciliary body procedure like a diode cyclophotocoagulation. This is just an overview that I put together of the different clinical trials that shows you, how that whether it's early glaucoma, whether it's moderate glaucoma or severe glaucoma, if you intervene, it'll retard the progression of glaucoma. So for early phase, we have the ocular hypertension treatment study, the EMGT study, GLT, SIGITs, and the other extreme, we have the advanced glaucoma intervention study. Notice, though, that the treatment paradigm in the early phase was pretty much pharmacotherapy and trabeculoplasty. And then if that doesn't work, then we go to the other extreme, which is basically trabeculectomy or tube shunt. But the irony is, in all of this, that this is the range we're at. We're two extremes. There's nothing in between to help our patients. And we know that pharmacotherapy in long term will result in changes in the conjunctival tissue, and that itself can actually be an obstacle in terms of increased risk for trabeculectomy failure. When you have the conjunctival tissue exposed to the preservatives, benzalkonium chloride, it may end up to be a failure. And therefore, it may not be ideal when you do trabeculectomy as to why these patients continually struggle all along. And with medications, you have a lot of side effects. We've talked about it. Dr. Khaimi covered this earlier this morning. The cost is an issue. Dosing is an issue. The more the patients have to take eye medications, the more difficult it is for them to be compliant, either because of cost or because they rely on others. 20% of elderly patients rely on others to give them their drops, squeezing. They may take the drops, but they may not be getting in. And they may not be able to read the bottles because they can't see. And then when that doesn't work, we subject them to a trabeculoplasty and then ultimately to the other extreme, which is filtration surgery. We need to keep in mind, this is from ICOMED, my good colleague just north of me in Canada. We share a lot of patients together. And he pointed out that in a typical glaucoma practice, you have about 60% of your patients, about two-thirds of them really, are basically what we call the middle class. They're mild to moderate glaucomas. And you have about 10% who really have advanced glaucoma. They're the ones who need the trabeculectomy or the tube shunt surgery. And so what do you do with these 60% of patients? It's really not fair to subject a patient with mild to moderate glaucoma who's failed pharmacotherapy or laser surgery to the other extreme of undergoing an invasive procedure that may be not good from long term. And about 30% are controlled, the early mild patients. And so that 60% is what we need to try to change the paradigm in terms of this landscape, how we can provide better care for them without compromising their visual function. And of course, you know, with the trabeculectomy, which is basically a non-physiological pathway, you have thinning of the bleb, you have a bleb leak, you can have extension into the intrapalpebral fissure, you can get hypotony maculopathy, you can get, you know, blebitis, or even to the extreme of a hypopion or a hyphema, which is, you know, full of complications in patients who continue to progress. Harry Quigley from Johns Hopkins pointed out that vision-threatening complications of present surgical techniques, vision-threatening complications of our own hands that we do for our patients, including dysfunctionally low intraocular pressure and late infection, mandate research into new approaches to glaucoma surgery, and that is so true. This is just a work by Dr. Ramalu from Johns Hopkins, who showed what the trend is for the last 10 years, from 1995 to 2004, looking at Medicare claims data. And what he found was that primary trabeculectomy has gone on the downswing. Almost 50% reduction within the first 4 to 5 years, a significant drop when they had no previous surgery. But those patients who are undergoing trabeculectomy who had prior surgeries, that stayed a constant around 10,000 in his analysis. Interesting, at the same time, during this dip, there was a significant increase in the number of laser trabeculoplasties that were being done at the time when trabeculectomy was on a decline, suggesting that patients, at least physicians, are looking for alternate ways of lowering intraocular pressure without compromising function. If you put these two graphs together, you can see with the downslope of trabeculectomy, there's an upslope of trabeculoplasty. And one of the explanations by Dr. Ramalu is that this perhaps indicates the introduction of selective laser trabeculoplasty around that time. Of course, we know about Otto Barkan. He's the one who described goniotomy back in 1936. Think about how long ago that was. And my good colleague in Hyderabad, India, I met him recently, Dr. Mandal, good glaucoma pediatric specialist. He wrote a wonderful article in the Bengal Ophthalmology Journal in 2012, and he basically noted that not much has changed since the time of Otto Barkan until 2006. 70 years have gone by when angle surgery was actually the forte of pediatric ophthalmologists. It did not reach the realm of the adult glaucoma until 2006 when the FDA approved the trabectome. And what is microinvasive glaucoma surgery? This is a big hot area that Ike has spoken quite a bit about. Some of these are his slides on a hallmark paper he wrote, this fellow, Dr. Saheb. Basically, it's an ab interno approach, as Dr. Khemi pointed out earlier this morning. It's a clear corneal microincision, which is about 2 millimeters or less. It's conjunctival sparing, so you can do surgeries if these don't work later on. It's minimally traumatic. It definitely is. It takes very little time to do. There's minimal alteration of the normal anatomy and physiology. It has excellent biocompatibility of these devices. Has at least modest efficacy because these patients have mild to moderate glaucoma. We're not looking for pressure under 12. It's extremely high safety profile and rapid recovery, especially in those patients who are very elderly or monocular. This may be the way to go. And what's nice about microinvasive glaucoma surgery in this landscape of this, what's happening in the shift in glaucoma surgical decision making is that it addresses the root of the problem. As we mentioned, that tube shunt surgery and trabeculectomy are non-physiologic outflow pathways that we create. But this addresses the root of the problem because the outflow resistance is the trabecular meshwork and the inner wall of Schlemm's canal. So this allows us actually for the first time to have early intervention in glaucoma to avert blindness. And it may be at some point that glaucoma is going to become primarily a surgically treatable disease and not medically. It preserves the conjunctival real estate, but it does not prevent future invasive surgeries if they are required. It allows the patient to maintain the quality of life, and it enables us to maintain pressures that may be acceptable for mild to moderate glaucoma. And the outcomes, usually in my hands, the patients will experience a reduction in number of medications that they are taking, and usually it's often combined with cataract surgery in the United States. This is a picture from one of my papers wrote in 2014 showing you the main outflow pathways. The first is the conventional outflow pathway, trabecular meshwork. Another target of microinvasive glaucoma surgery is the uveoscleral outflow pathway through the ciliary body face, as Dr. Khemi pointed out. And the third is the subconjunctival space area. And these have been the areas that have been much focus of multiple companies that each landmark has so many procedures that are already being invested. For example, in trabecular meshwork, you have so many, as you can see there without me repeating it in front of you. The suprachoroid has a side patch that was recently approved by the FDA in the United States. And of course, you have the InFocus and Zen, and future MIGs in clinical trials are yet to be conceptualized. So this is a summary of where we're going in these targeted spaces to treat the outflow pathway, to restore a physiologic pathway. Of course, one of the bypasses that's the forerunner, and this was is the iStent, which is a 1 millimeter half pipe. That's put into the canal. It's got 3 retention arches, as you can see in the upper left. It's really a very delicate surgery, and it basically is heparin coated, and it's a titanium-based device. It's a preloaded applicator, and you can see it sits very nicely in the trabecular meshwork, and it's minimally invasive and really minimal harm to the patient. This goes to show you a little video here, if I can get this running here, showing you a typical procedure where basically here's a patient who's phakic, and this is IconMed putting 2 in, because we can't do phakic patients yet in the United States. And you can see how elegant it is. It doesn't take very long. He basically inserts it into the Schlemm's canal and just taps it to make sure it's completely inserted and checks his vertical memory. He'll put a second one in for there's a right and a left handed iStents available commercially. He'll put both of these in. And that's pretty much the surgery. And that's a lot less time than doing a trabeculectomy, right, Dr. Subhan? So you can see it's quite a elegant and easy procedure to do, and you're not going to mess up the patient's eyeball. It's as safe as doing cataract surgery. And that's just showing you the heme that can come, indicating that you're in the right anatomic place, because you're dealing with the venous sinus, the Schlemm's canal, indicating you're in the right anatomic space. If you inject trypan blue at the end of the case, you can see that there is an actual communication with where the arrows are, a beautiful uptake of the trypan blue in the episcleral vasculature, indicating how beautiful and elegant this procedure is for someone who's got mild to moderate glaucoma. And you can actually see blanching as well in that area. And for the sake of time, I'm going to continue moving here. So you can see how beautiful this is. And you can actually see the intraoperative success of your surgery, and hopefully that's an indicator of a successful outcome for your patients. So again, what's your choice? You want trabeculectomy with a pressure of 12 and no meds, intense postoperative course. It's really hardship for both the patient and the doctor, right? If they have to cut, you have to suture lysis or pull a releasable suture, it's a lot of work. Or you can put in 2 or 3. In most of my patients, I put 2 iStents in most of my patients. And they're happy. It's enough to keep them going. And they may be on 1 bottle as opposed to 3, but they're happy. They have an easy postoperative course, and not only do they see better with their cataract surgery, but they're also able to enjoy not having to take 3 bottles, but only take 1 bottle at bedtime without any systemic side effects. Of course, a study by Ike showing that if you put 1 or 2 in, if you put 2 stents, it gives you about a 33% drop, and putting three of them in really doesn't add much in terms of the pressure drop, but it may enable them to get off another bottle of medication. So I go with the 2 for me, and that works for most of my mild to moderate glaucoma patients. Of course, there's the Glaukos iStent G2, which will be coming out. We're going to have 2 of these put in. You don't need to do a left or right. You just put it right into the Schlemm's canal, and that hopefully will be commercially available in the next year or so. Of course, the trabectome's been around for a while. Basically, it's a foot plate that you enter into the Schlemm's canal, and it just using electrocautery, and it just basically unroofs the Schlemm's canal and allows for fluid to have access. The aqueous have access to the collector channels. Hydrus is another device which is basically 3 clock hours. You can see it's got some windows there. They're specifically open to have allowed the access of aqueous to the collector channels that push the trabecular meshwork on stretch. And it's something that I think is in clinical trials right now and may be hopefully available at some point. And I think this picture you saw earlier today with Dr. Kami showing you both the cartoon and an actual intraoperative photograph of how it covers 3 clock hours, hopefully enabling aqueous to have access to the collector channels in a much larger arc. The suprachoroidal space is very interesting. It's actually unique in that the anterior chamber pressure is greater than the pressure that's actually in the suprachoroidal space, so there's a natural gradient for water to go from the anterior chamber to the suprachoroidal space. And this differential enables for companies to take advantage for devices as CyPass and iStent Supra. This is an example of CyPass, and it's basically about 11 to 13 millimeters long. I don't have the exact numbers here, but you can see there's basically like a long, has multiple perforations. It's actually injected through the ciliary body into the suprachoroidal space. And at least in Ike's hands, he has not had any case of a suprachoroidal hemorrhage or a vision-threatening complication. So it seems to be very safe. And you can actually measure the success of the pressure lowering based upon the lake effect around the actual this device by doing ultrasound, anterior segment imaging. The iStent Supra is the Glaukos version of it. It has 4 rings and it has the same concept, and I'm assuming at some point it'll come out as well. A similar idea. It's non-pyrogenic, it's non-ferrous, and it's irradiated. Has retention rings to provide stability post-implantation. The Aquasys is another device made from permanent gelatin, about the size of a human hair, as you can see. It's very small, and it comes preloaded in the intraocular lens like an inserter in a dehydrated state, and it's basically injected through the angle into the subconjunctival space, and it bypasses all points of resistance to the subconjunctival space.
1 minute, please.
It's 20 minutes, right? I thought I had 20 minutes. Wallahi? Okay. So this Aquasys here, and this is an example of that. I'll just move quickly here. So basically, you have different types of procedures depending on your target intraocular pressure, whether it's early, moderate, or severe field loss. You can pick the type of procedure. Do you want to do phacoemulsification? Do you want to do a MIGS procedure? Do you want a blebless ab externo glaucoma surgery, like ab externo canaloplasty or trabeculectomy? And so I think that middle section now, the two extremes of medications and trabeculectomy and tube shunt, we have the microinvasive glaucoma surgery that's filling in that void. And so depending on what you want, and these are all the different type of devices and the procedures available, and the target IOP that you're starting with, you can now titrate the type of procedure you want depending on what your ultimate goal is in intraocular pressure. Again, all of these devices fill that extreme of trabeculoplasty medication to tube shunt surgery. And this basically is very important. Some people say, my surgery doesn't work, this is a terrible device. You need to understand the anatomy. You need to understand the anatomy of the outflow pathway if you want to try to target and get a good result in your and I'm just going to do a quick picture here. We're at the very end. Basically, you want to aim for the aqueous vein, that white little vessel over there. There's a direct communication between the Schlemm's canal and the episcleral vasculature. Those veins of Asher, there's about 4 or 5 of them. That's where you would like to target your device, and it'll actually allow the drainage at 1 microliter per minute, which is quite impressive. And there's also been evidence that if you put your device, if you're putting one in the area of more pigmentation, that you're going to get a good reduction in intraocular pressure. And this here is my last slide, showing you that just like patients with heart disease, you start them with medication. You don't automatically do open heart surgery when the heart medication doesn't work. You now have balloon angioplasty, you have stents you can put in. And along that same paradigm in glaucoma, we also have now medications, we have stents, we have bypass procedures for suprachoroidal surgery, and of course you have a trab and your tubes. I hope this has been helpful for you. Jazakumullah khairan for your attention.
So the marathon continues. Well, thank you for being here. I can't believe you're all here. We're also getting tired. But I'm going to discuss a different type of glaucoma now, which is also a very complex type of glaucoma, and that's neovascular glaucoma. Earlier this morning, I spoke about normal tension glaucoma. I can tell you as a glaucoma specialist, both of these types are rather difficult to treat. And one theme about both of them is that it's really important to have a team approach and speak with their internists and primary care providers so we can provide a more comprehensive care to these patients. I'm going to focus mostly on management of neovascular glaucoma today. So, as you all know, neovascular glaucoma is a secondary angle closure glaucoma. We have formation of abnormal vessels and fibrous tissue in the drainage angle. Over time, these can contract, cause synechial angle closure, leading to blockage of angle, high pressure, and then problems start. So the way I look at neovascular glaucoma is to divide into different stages. There is stage 1 or pre-glaucoma stage. Here we may see rubeosis, but the angle is normal, the pressure is normal. This is the best time to make the diagnosis and intervene for whatever the underlying condition is. If we're a little bit late, then we get to stage 2. Here we see rubeosis, the angle is still open, but you see NVA, neovascularization of the angle, and the pressure is high. At this point, we still have an opportunity to take care of this because the high IOP can be controlled with conservative measures. Stage 3 is when you have angle closure glaucoma. You have sneaky closure with high pressure. This is a tough situation. Here, we still do our conservative management first, but often patients require surgical intervention to control IOP at this stage. You all know there are many, many different causes of neovascular glaucoma that can lead to retinal ischemia, but the 3 main common causes remain diabetes, central retinal vein occlusion, and carotid occlusive eye disease. The main culprit is retinal ischemia. In response to ischemia, angiogenic factors are released. They find their way, they navigate to the anterior segment of the eye, cause rubeosis and angle neovascularization. Now, the management of neovascular glaucoma can be divided into 2 stages, acute management and chronic management. The focus of acute management is to make the patient comfortable and reduce IOP. And you can reduce IOP by medical therapy, mostly aqueous suppressants. Paracentesis can be done in an acute situation, but these eyes are so inflamed and they often bleed. Anti-VEGF therapy should be employed as soon as possible to help with regression of NVI and NVA. And once you have a clear window to the back of the eye, PRP should be done. If you're dealing with chronic management, this is when surgical intervention for glaucoma is necessary, and the 3 commonly performed surgical interventions remain to be trabeculectomy, glaucoma drainage device, and cyclophotocoagulation diode laser. So with medical therapy, just a few more words. With aqueous suppressants, I hear this from some physicians and some trainees, that if a patient is doing topical carbonic anhydrase inhibitors, some people are a little bit afraid to put them on systemic. I do that. Obviously, you have to watch for the side effects of systemic CAI or Diamox, but I think for temporary treatment, it's okay. Also, I know NVG has an inflammatory component. I don't shy away from prostaglandin analogs because you want to hit them as hard as possible and try to obtain as low IOP as you can. Reducing inflammation, corticosteroids, we usually put them on topical steroids. There's very minimal data about use of oral steroids. As far as intravitreal steroids are concerned, actually Jonas and colleagues have looked into applying this, and they found good results, but this has not really become the standard of care. Cycloplegics are often started in these patients to reduce pain, decrease inflammation. Sometimes they can actually decrease IOP by increasing outflow through the uvascular outflow pathway, and they help to maximize view for PRP treatment. So let's move on to anti-VEGF therapy. If you look at the indications for anti-VEGF therapy, this is mostly for retinal diseases, macular degeneration or macular edema from either diabetes or vein occlusion. And their use for neovascular glaucoma remains as an off-label use. We have few different options, and most of the literature on neovascular glaucoma has been done using Avastin or bevacizumab. And why is that? Because Avastin offers many advantages. It has high efficacy, longer half-life, requiring fewer injections, much lower cost, wide availability, and lack of preservatives. Now, often they're given intravitreally, but you can also give them in the anterior segment. And this slide is just to remind you that sometimes the dose or the concentration may differ. Anti-VEGF therapy has become really the standard of care for NVG, but keep in mind there are no randomized clinical trials available to date comparing one compound with the other. Most of the evidence comes from retrospective and non-comparative case series. Their effect is short-term. They do make patients comfortable. They do reduce NVI, NVA, but they often use as a bridge before PRP or surgical intervention takes place, and often patients require repeat injections. It can, as I said before, it can be done intravitreally, intracamerally, subconjunctivally, topically. Anti-VEGF agents are interesting. They may reduce pressure, they may increase pressure, or they may do nothing to the pressure. there was a study done where bevacizumab was combined with PRP, so two arms, bevacizumab and PRP, the other one was PRP monotherapy. And in this study, they showed that the combined therapy led to significant IOP reduction and a higher frequency and rate of NVI regression. So bottom line is, if you're going to do PRP, combine it with the anti-VEGF therapy. Anti-VEGF therapy can also be combined with trabeculectomy, and studies have shown that these agents may act synergistically with traditional antimetabolites, either mitomycin C or 5-FU. However, some studies have not found any reduction in IOP with these agents, but there are reports of reduced post-op interventions. The anti-VEGF therapy can also be combined with glaucoma drainage devices, and this can lead to reduced bleeding, increased surgical comfort, and improved surgical success by reducing inflammation and scarring. This is a multi-center prospective randomized clinical trial that was done back in 2015, where bevacizumab was combined with the glaucoma drainage device. They had 40 patients, mean follow-up was almost 2 years. No difference in IOP was noted between the two groups. Once again, we saw the trend that there was better regression of NVI and a trend towards fewer drops after intravitreal Avastin. Now, I often send my patients to our retina colleagues for the anti-VEGF agents, and as you know, there are some side effects anytime you're injecting a needle into the eye. You can have vitreous hemorrhage, injury to the lens, retinal detachment, among other things noted here. But I, as a glaucoma specialist, get concerned about IOP rise, even though we're trying to help these patients with NVG, but sometimes you can have IOP rise, and this can be acute, and this can be sustained. Acute IOP rise is usually due to eyeballs' limited elastic capability to respond to the increased intraocular volume. It may also be due to the fact that the TM gets damaged and inflamed in these eyes. It may be the medication itself, its excipients, or perhaps its contaminants. The good news here is when you have acute IOP rise, often it normalizes within 30 minutes. What about sustained IOP? This is a little bit more concern because you have to follow these patients more frequently. The incidence is up to 11% in eyes without pre-existing glaucoma. However, if someone has existing glaucoma, the incidence is much higher. And if you have those patients, the amount of injection going into the eye should be smaller. And in these patients, you may want to consider performing paracentesis right after the injection. PRP is usually done by our retina colleagues, but the rationale for the treatment is to reduce retinal oxygen demand, reduce hypoxic stimulus, and reduce the release of VEGF factors. We know that PRP definitely leads to regression of NVI and NVA, but it takes a few weeks to do that. If we look at the central retinal vein occlusion study, they showed that prophylactic PRP was not necessary or effective. But if you see the appearance of rubeosis, you should do it, and then it does help. If you're going to do PRP, it has to be a complete treatment. You have to apply all the spots and cover all areas in the retina. Now, this slide is not to scare you. I know it's a very busy slide, but I just want to mention that there are studies done looking at outcomes of filtering surgery in NVG. The problem is it's difficult to compare one study with the other because patients are presenting at different stages of the disease. They have neovascular glaucoma from different etiologies. Success was defined differently. But this slide gives you the take-home message. In general, the outcomes of trabeculectomy in eyes with neovascular glaucoma are worse compared to eyes with primary open-angle glaucoma, and this is due to scarring, inflammation, hemorrhage, and fibrin. These outcomes can be improved with antimetabolites. You can use whatever you're comfortable with. There is no difference between 5-FU or mitomycin C. That's what we have seen from some studies. Also, the outcomes are improved with anti-VEGF agents. Again, a very busy slide with neovascular glaucoma and tube shunt surgery. Same challenges here as I described for trabeculectomy. take-home message, glaucoma drainage devices are probably better choices in these patients because we're not doing iridectomy, the eyes are not bleeding. This is a better option because we want to avoid hyphema and inflammation. What type of implant are you going to use? It will depend on your own preference. I personally like to use Ahmed because it is a valved implant and I want to have immediate IOP reduction. Also, many of these patients require concomitant retina procedures, and if they're getting those done, it's good to put these tubes in pars plana. So this way you're minimizing contact with the iris and you will prevent hyphema formation. Cyclophotocoagulation is still a good option. Traditionally, it was thought that perhaps it should be reserved for eyes with poor visual potential. But I don't think that's any longer the case. I mean, it's effective, it's quick, there's no bleeding risk. Yes, there is some concern that given the inflammatory nature of neovascular glaucoma, eyes which get CPC laser may get hypotenuse. So my recommendation is titrate your treatment. Maybe treat 180 degrees at a time, and hopefully we can avoid these complications. There was a large study done by Ansari and colleagues where they reported the outcomes of CPC in different types of refractory glaucoma, including NVG. And they reported 43% IOP reduction. That's pretty significant. They also reported 58% reduction in use of glaucoma medications. And the patients had good outcomes in terms of vision. So the recommendation after this study was CPC is highly effective and safe for various types of glaucoma, including neovascular glaucoma, and its use can be extended to eyes with good vision. There was a study done which compared CPC and Ahmed glaucoma valve. Some of us have this conception, let's do the drainage implant first and maybe CPC later, and that's okay too. But I want to share these results with you because this was an interesting study. They started with a pre-op IOP of 43. Post-op IOP at 24 months was about 16 millimeters of mercury in the CPC group and 22 in the Ahmed group. And the authors concluded there was no significant difference in outcomes between CPC and Ahmed glaucoma valve. Unfortunately, despite our best efforts, we have many eyes which become end stage and they are blind. And for those eyes, we can do something conservative like a retrobulbar alcohol injection, or sometimes the eye may have to be removed. So in summary, I would say it's important to get on the phone, speak to the internist or primary care doctor or whoever is, or your retina colleague, treat the underlying disease. That is the key to success of treating neovascular glaucoma. Anti-VEGF therapy is a must. It leads to regression of NVI and NVA, but realize its limitation. It's a short-term effect. It's not a permanent solution, but it's a very useful solution, and it serves as a bridge before you do PRP and surgery. The supporting data for choice of surgical procedure is not strong. It's really not clear which is better, trabeculectomy or Ahmed glaucoma valve. I would say most surgeons prefer tube shunt surgery, and that's also my own personal choice as well. CPC is still a good option, and it should be employed in eyes with good vision as well. You do not have to limit this option to only advanced disease. The most common cause of treatment failure in these eyes is progression of underlying disease. So pay attention to the underlying etiology. Thank you so much for your attention.
Let's talk about the in-focus shunt, and let's do a little bit of a historical background. Just about 10 years plus, if you look back to 10 years ago, we really didn't have much for surgical armamentarium from a glaucoma standpoint. In fact, most of these were invasive procedures that carried a risk profile alongside them. Recently, as I mentioned earlier on, there has really been an explosion in different procedures due to the interest in hopefully creating procedures that are less invasive with less complications. As you can see, the list is quite expansive now. Furthermore, most of these procedures now can be combined with cataract surgery, and because they're minimally invasive, we're doing cataract surgery alongside with them to treat both morbidities. Now, why such a interest in this area? Why such a huge explosion in the different amount of glaucoma procedures coming out? Well, if you just take a look at this slide, you'll understand perhaps a day in the life of a glaucoma specialist. You know, I don't want to wake up in the morning thinking I'm going to come to clinic and see any of these. This is something that I want to avoid. And so, of course, this is the impetus for us to try to develop newer procedures that are less invasive. So hopefully we don't have to see these anymore. Which brings us to the in-focus micro shunt. The shunt here is, you can see on the diagram, and just to get an idea of just how small it is on the fingertip there. Now, earlier I spoke of mechanisms of surgically lowering intraocular pressure. So, of course, as you recall, Dr. Shakil Sharif did a really good job at explaining that you can decrease aqueous production, we can promote flow of aqueous to subconjunctival space, or the conjunctival outflow pathway, or suprachoroidal space. When we talk about the in-focus shunt, we're talking about redirecting aqueous to the subconjunctival space via an ab-externo approach. So if we look at the in-focus shunt, it's made of 100% SIBS material, and this is a biocompatible material that actually has no degrading bonds. And because of that, it doesn't cause any inflammation, as silicone would perhaps, and is very biocompatible. Furthermore, the in-focus shunt itself is soft and flexible and compliant, so hopefully that will keep erosions away. As you can see on the shunt itself, it has these fins to prevent migration and periannual leakage. And the outer diameter is 350 microns. The lumen diameter, the inside lumen diameter, 70 microns and 8.5 millimeters in length. Now, here's a diagram of what this shunt looks like in the eye. Of course, one has to do a conjunctival peritomy to gain access to the sclera, and then the shunt is placed through a scleral passage into the anterior chamber. Now, the in-focus was first looked at in the Dominican Republic and France by two ophthalmologists, and they looked at 35 patients. Mean age was 62, and their baseline IOP was just about 24, and their diagnosis was primary open-angle glaucoma, and these guys were just about on 3 drops of medication. Post-operatively, their intraocular pressure was very well controlled, down to an average IOP of 11.3. So a substantial drop in pressure at about 2 years. As you can see, this is the famous aegis zone of no progression, or no progression of vision loss. So the other thing that was noted in this study was that there was no serious adverse events. There were no incidents of endophthalmitis, chronic hypotony, choroidal hemorrhage, vitreous hemorrhage, tube obstruction by the iris, blood, fibrin postoperatively, or any corneal touch. So it was a pretty safe procedure. The in-focus study also showed that there was a 100% success rate at 1 year in this particular study. There was no long-term sight-threatening adverse events, and we went over the data. The conclusion from the study was that it was the in-focus microshunt was immediate and a safe way to decrease intraocular pressure. Like I said, there was no adverse events, and a very doable surgery which can be an alternative to glaucoma drainage implants or trabeculectomy. So in the United States right now, we're currently doing a clinical study. I'm a primary investigator at the Dean McGee Eye Institute, and the study is a randomized study comparing the safety and efficacy of the in-focus microshunt glaucoma drainage system to standard trabeculectomy. So this is in-focus shunt versus standard trabeculectomy. The primary effectiveness outcomes were mean diurnal IOP reduction from a baseline at 24 months follow-up, and secondary outcomes were proportion of eyes with greater than or equal to 20% reduction in mean diurnal IOP from a baseline to 24 months postoperative examination. The study design is that it's a prospective, randomized, controlled, single-masked study. So it's as good as it gets, and is really it's currently the largest study conducted in the United States. It's phakic and pseudophakic stratified, multi-center trial. So there are several centers in the United States doing this study, and there are 2 study groups. Like I mentioned, one is the InFocus, and the other one is the trabeculectomy, both with mitomycin C. There are 2 phases to the study with 2-year follow-up. We are currently now past phase 1, and we're actually recruiting for phase 2. And so let's take a look at this procedure. So here, a traction suture is placed through the cornea so that you can rotate the globe inferiorly, and a conjunctival peritomy is created at the limbus. Mitomycin WECs are then placed. This is at a concentration in the United States at 0.2 milligrams per cc for 3 minutes. At this point, a caliber is used to mark a site 3 millimeters posterior to limbus. They do advocate a large conjunctival peritomy, and I'm denoting there almost 9 to 10 millimeters there. With a 1.0 Cyport Manny blade, you fashion a scleral passage to just about the anterior chamber, at which point a 23 gauge needle is then used to actually enter the anterior chamber. The InFocus shunt, you can see how flexible it is then placed through that scleral passage into the anterior chamber. You'll see how the fins keep the implant in place. And then we have to prove to ourselves that we're actually getting egress of aqueous, and you can see the little trickling of aqueous coming out. And then great care is taken to close up the conjunctiva, making sure that the tenons does not obstruct the opening of the shunt distally. And then you can close the conjunctiva like you normally would after a trabeculectomy. So let's kind of compare this to what we're familiar with, and that's with trabeculectomy. Here you have a scleral flap and you have sutures. So as you can see with the InFocus, you don't have any of that. You don't have to create a scleral flap or sutures, and that was for trabeculectomy using express shunt. For those of us who still do traditional trabeculectomy, there's no use of the Kelly punch. There's no sclerectomy created. Nor is there a need for a surgical iridectomy. So you can already see how less invasive this procedure is than a traditional surgery. Now at week 1 post-op, this is what the eye looked like, nice and quiet, with a nice posterior diffuse bleb. And at 1 month post-op, you can see the implant in very good placement with the appearance of a nice diffuse bleb. So hopefully in a couple of years we'll have results for the long-term study, and we'll be able to obtain FDA approval, at which point I can imagine multiple studies being carried out. And thank you for your time.
So I have no disclosure in this talk, and I'd like to thank Professor Balchohan, Alexander Rees, Neil O'Leary, and Marcelo Nicolela for their support in doing my research with them. So classically, when we talk about optic nerve head complex evaluation, we are talking about certain things. Number one, we need to define the optic disc margin or the clinical disc margin, from where we can go and detect the neuroretinal rim. We can assess by this the cup. Then we need to look at the lamina cribrosa, scleral ring, peripapillary atrophy, and any nerve fiber layer defects. So when we talk about the clinical disc margin, it's a clinical landmark defined to be the inner edge of the scleral crescent or the Elschnig ring or the border tissue. And on the other hand, the border tissue is a fibrous tissue that raises up from the anterior edge of the sclera to fuse with the Brooks membrane to separate the choroid from the RGC axons as they pass through the anterior portion of the neural canal. Now, the Elschnig ring, or the border tissue, is highly relevant to the disc margin, and its anatomy relative to the anterior edge of the sclera determines whether or not it's visible to the clinician and what structure is perceived as the edge of the optic disc. Now, there are some certain facts. The optic nerve head evaluation is a subjective process. So intra and inter-observer variability in detecting changes do exist. It's a poor method for detecting glaucomatous progression as well. And there are several issues. Number one, that the examiner's experience and training affect glaucoma diagnosis on clinical disc assessment. Number two, difference in knowledge and characteristics of glaucomatous optic nerve head also plays a role as well. There are some certain variabilities in the optic nerve head size and appearance that could affect our assessment of the disc, whether it's glaucomatous or not. Even glaucoma experts may not necessarily demonstrate good intra and inter-observer agreement as well. We should realize that structural changes usually precede reproducible visual field changes as well. So there is no agreement on the disc margin nor disc margin as well. Now, if I would ask each and every one of you to tell me exactly where is the disc margin in this disc photo, some of you might say that actually this is the disc margin from which you can assess the neuroretinal rim, but some of you might say that actually this is the disc margin. So disagreement usually occur between general ophthalmologists and glaucomatologists as well. Now, since the introduction of OCT from the time domain till spectral domain optical coherence tomography, we had a high resolution and high improvement in OCT-derived images and high acquisition speed as well. This resulted in having this wonderful and clear B scan derived from the OCT. So such an image and clear image, which allowed us actually to do an in vivo histological assessment of the optic nerve head, allowed clinicians to perform an assessment of what we see as clinicians perceived as the clinical disc margin. So just an overview here of what we have. We have here the Brooks membrane opening, and that's the Brooks membrane. So it ends in the Brooks membrane opening. We have the lamina cribrosa down here, and the prelaminar tissue. We have the border tissue, and we have the internal limiting membrane. So in OCT, whenever you want to assess the cup volume, the machine just will drop a horizontal line going from the Brooks membrane opening. Then it will segment the internal limiting membrane within the cup. So by this, it will estimate for us the cup volume and subsequent the vertical and horizontal cupping of the optic nerve head. However, there are several concerns that what we perceive as a clinical disc margin, what does it contain actually? What structures under the disc margin that we see clinically? Because of that, one study was done by Balchauhan and colleagues, and the aim of the study was to co-localize SDOCT images to stereo disc photographs of glaucoma patients with variety of optic disc appearances and normal controls from which the clinical disc margin was determined. The basic objectives of this study was to detect the border tissue orientation, being internally oblique, externally oblique, or non-oblique, identify the SDOCT detected optic nerve head structures that coincide with the clinical disc margin, being either the Brooks membrane opening, the Brooks membrane and border tissue, or only border tissue, and to determine the frequency of SDOCT-derived Brooks membrane extension beyond the clinically visible disc margin, which we call Brooks membrane overhang. So these are the types of the border tissue orientation. We have figure A, which is an internally oblique border tissue. B, internal oblique border tissue with a Brooks membrane overhang, which is the clinically invisible extension. We have an external oblique border tissue, and we have in D a non-oblique border tissue. Now, the structures that coincide with the clinical disc margin will be either Brooks membrane opening, like in A, or Brooks membrane with border tissue, like in B, or border tissue alone, like in C. So what I've done is that the stereo disc photos were resized and registered to an IR image extracted from the OCT-B scans. So after registering these photos, you were able to project whatever you see on the stereo disc photos, which is registered on the IR image, to the B scan and vice versa. Whatever you segment on the B scan will be projected to the stereo disc photo and IR image. So you can see here that this green dots represent the clinical segmentation of the disc margin, which is on the stereo disc photo and projected on the IR image. What you see here in the lower part, the red dots represents the Brooks membrane opening, which is the true anatomical boundary of the neural canal, and it's projected on the IR image as well. So if you can look at both, images, just I made it, bold so that you can see enough, or it can be clear for you. There is some discrepancy between the clinical segmented disc margin and the Brooks membrane opening, which is the true outer limit of the neural canal. Again, so if you look at this clinical disc margin and the projection of what we see on the B scans, and compare it with the Brooks membrane opening and its projection on the stereo disc photo, there are some discrepancies, which is clear very here. So instead of estimating that this is actually the residual rim, the rim now seems to be a little bit thinner than what we thought. Again, there is another example. So we can see that there is no discrepancy here in this temporal part, but in the inferior part, there is some discrepancy in which the Brooks membrane opening is actually external to the clinically detected disc margin. Another example. And in this video, just I'm going to show you how does it, appear all over the optic nerve head. So you can see that in this area, sorry. So you can see that there is some discrepancy in this area between the clinically visible disc margin or the clinically detected disc margin and the Brooks membrane opening. Another example, just I'll skip it for the sake of the time. So what was found in this study is that when you look at the distribution of the obliqueness of the border tissue in glaucoma patients and healthy control, you would see that the greenish color represents an internally oblique border tissue, which is more prominent superiorly and nasally in glaucoma patients, while it's prominent all over in healthy controls. An external oblique border tissue is more prominent inferotemporally in glaucoma patients as well. When we look at different glaucoma phenotypes like focal, diffuse, and sclerotic, we see that an external oblique border tissue is mostly present in a focal optic nerve head damage inferotemporally, while the internal oblique mostly present superionasally. In the sclerotic, mostly superior nasal and temporal, we have an internal oblique, while inferiorly we have external oblique, while in the diffuse part we have mostly internal oblique. And we'll come to the importance of this right now.
1 minute.
Okay. Only 1 minute? Can I have just 5? I'll just run over. Just 5 minutes.
We're already late,
okay.
So please.
So the SDOCT structures most commonly coincide with the clinical identified disc margin in glaucoma patients and controls was a location on Brooks membrane with border tissue beneath, mostly inferotemporal to superionasal, both patients and controls. In the Brooks membrane overhang, it was present in the majority of patients and controls. In patients, BMO corresponding to disc margin was 19% to 54%. In controls, it was 0 to 80%, and the Brooks membrane overhang was not clinically visible, meaning that we are having some overestimation of the residual rim. So in glaucomatous focal damage, more external oblique border tissue, especially inferotemporally, is present, and in clinically disc margin and CSLT-based or examination, we might overestimate the remaining rim, especially in Brooks membrane overhang. Now remember that when you go to Garway heat map, most important area for us is the inferior, inferotemporal, and superiotemporal part as well. which feeds or which receives the fibers and the axons from the foveal area. In clinical, photographic, or CSLT, rim width measurements are made in the plane of a perceived disc margin without reference to the orientation of the rim tissue. So for the same number of axons, the rim width will be greater in cases where the orientation of the rim tissue is more horizontal, which is in the temporal sector of tilted optic disc, where there is an external oblique border tissue compared when it is more perpendicular. That's why we came with the minimum rim width principle.
We need to conclude. We need to finish. 1 minute was 2 minutes ago. We need to conclude, please.
Sure. So there was a study which was done to evaluate the accurateness or the importance of the minimum rim width, which will take into account the orientation of the ganglion cell axon orientation in relation to the border tissue. And it evaluated the diagnostic performance and compared it with the RNFL and the BMO horizontal rim width, and it was superior to both regionally and globally. So, can we actually rely on such a parameter on automated segmentation? The answer is yes, we can rely, and the segmentation's error will actually less than 2 to 3 pixels or micrometer. So the last slide, should we stop clinical disc assessment based on the facts that we have here on SDOCT images? The answer is no, because the color and health of the rim regionally or by clock hour can be assessed only clinically. Bowing or excavation of the optic nerve head surface is important as well to be detected clinically, which cannot be done by OCT-based images. Disc hemorrhages can be detected clinically as well, and peripapillary nerve fiber layer defects can also be detected clinically and much more easier than the SDOCT images. So should we always use the SDOCT in our practice? If clinical disc examination is normal, the answer is no. If clinical disc examination is suspicious, SDOCT will provide an anatomically accurate assessment of the neuroretinal rim. However, clinical examination is still a cornerstone in glaucoma assessment and management. Thank you very much.
Assalamu alaikum. It's a great honor and pleasure to be here. Bismillah ar-Rahman ar-Rahim. So Ahmed versus Bearvelt, which device is better? I have no financial disclosures, so what you see is what you get. So when we look at glaucoma drainage devices, we see the Ahmed implant valve. And just a show of hands, if you're still with us, show who in the audience do the Ahmed valve, who have been involved with the surgery or assisting or seeing it. So we have been the Bearvelt implant. So I want to see a show of hands of those who do the Bearvelt implant or have been involved. So a couple. I don't see any of my fellows here, so at least I know who is in attendance. So when we decide about an implant or anything in life, which is better? Well, on the right, you see these nice pair of shoes. We have a meeting, we have a formal invitation. That's appropriate. But I'm going to go walk 2 miles, or I'm going to go for physical activity. Maybe these tennis shoes on the left are more appropriate. So if we have to ask which device is better, it really depends on our needs. So let's look at the Ahmed and Bearvelt question. Which is better? Again, what is our needs? So what is the target pressure? What is our endpoint? What type of glaucoma is this? Have they had glaucoma surgery before? What's the status of the conjunctiva? These are all questions that we have to think about. What is the follow-up or patient reliability? If I have one surgery and I don't want to have to do manipulations post-operatively, I need to have that information ahead of time. So let's look at some of the studies. The AVB study. 3 years out, both implants had about a 49% success in the Ahmed group and 66 in the Bearvelt group, and this was statistically significant. If you look at IOP, it was not a significantly different results at 3 years, 15.7 versus 14.4. Now, if you look at the 5-year results, these were just posted in the Blue Journal of Ophthalmology in October, 2 months ago. Results were comparable between the implants, but IOP started to increase in the Ahmed group, 16.6 versus 13.6, about a 3 millimeters difference, and that was statistically significant. And this is what we've seen in clinical practice. For those of us that have been doing implant surgery, I've been doing it over 15 years, this is not a surprise, but this was a prospective study that validated what we saw clinically. Visual acuity was comparable. The two groups had similar complication rates with a little more tendency of hypotony as a complication in the Bearvelt group. The ABC study, another prospective study that was randomized between Ahmed and Bearvelt at 5 years, you look at 14.7 in the Ahmed group versus 12.7 in the Beervelt, and that's statistically significant. Again, only 2 millimeters of mercury, but keep in mind, there is a multitude of glaucoma patients that are in these studies. What you see for uveitis or neovascular may be very different. Number of medications was comparable, 1.8 and 2.2, and success was about 55 in the Ahmed group and 60 in the Beervelt. So again, comparable. Acuity also was the same. So again, we have to ask the question, which implant is better? Well, let's look at safety profile, complication rates. Again, the key difference between the Ahmed and Beervelt is chronic hypotony, a little more common in the Beervelt group, whereas encapsulation leading to higher IOP in the Ahmed group. So when we look at both of these implants, hypotony and encapsulation are common to both. Those people who've been doing these implants for years, they know that encapsulation happens with the Beervelt as well, and those who do Ahmed valve know that sometimes you get hypotony. The valve is a flow restrictor. Sometimes it doesn't always function the way you want it to. Complications, Dr. Sharif, Dr. Jaime, Isam Osman, they've elucidated all of these. Hypotony we've already discussed, and the related complications of choroidal effusions and hemorrhage or flat anterior chamber. But corneal decompensation, double vision, tube plate issues, tube blockage, they're the same in both groups. It's really not a function of one device or another. It's more patient specific. So what I've come up with is an algorithm, especially for those who like things very simple. So with Ahmed implant, we have an A. When you think of A, those are the indications for an Ahmed implant. So the first A is altered ciliary body. Anything that affects ciliary perfusion or ciliary inflammation, that would be an indication for me to use an Ahmed valve. So chronic uveitis, neovascular glaucoma or ischemia to the ciliary body, prior cyclodestructive procedures, again, multiple intraocular surgeries or a history of endophthalmitis. Unfortunately, when we see some of our tube shunts and they get endophthalmitis, the only thing that's good is their pressures actually do pretty good for a while because of the ischemia to the ciliary body. A, abnormal anatomy. Well, children, microphthalmus, nanophthalmus, these eyes are at high risk for choroidal effusions and hemorrhage. Ahmed valve is preferred over a Beervelt in these situations. Look at advanced age. Again, look at the A's. So back home, we have a lot of elderly patients in their 90s. And they have progression. You can't do these micro procedures that we've seen. They have angle closure. In these situations, I like an Ahmed valve sometimes as a primary surgery. Doing a trabeculectomy in an 85-year-old may not be the best option, and they have thin tenons and conjunctiva, and Ahmed valve is a great situation in these patients. Now, we look to the B. So Beervelt indications, think of the letter B. So the first is B for black, and that's just a reminder that patients with increased pigmentation, African-American patients back home, or people from the African continent in general, Indians, and of course people in the Middle East. Patients with pigmentation tend to have more encapsulation. Who here has never seen encapsulation with Ahmed valve? I mean, it happens, and that's the frustration. You feel great for a week or two, you see the hypertensive phase. So these are indications for me for a Beervelt implant. B for buphthalmus. So in general, congenital glaucoma patients that have not done well with primary procedures, whether in the West, whether it's an otomy, goniotomy, or trabeculotomy, or here in the kingdom, deep sclerectomy. I see Dr. Jadan here and some of the pioneers. When you see their deep sclerectomies and they work, it's great. But what if they fail and scar down? In these situations, if you do another deep sclerectomy, that's an option. But doing a Beervelt implant is really indicated for the most part. Now, if they have advanced cupping, again, you have to take this with a grain of salt. These are guidelines. This is not the gospel. Scleral buckle. If patients have had retina surgery, and again, I'm reminded by Professor Saleh here, the best source of patients for us is our retina colleagues when it comes to all the oil and gas and manipulation of the conjunctiva. If they've had a scleral buckle and you're trying to put an Ahmed valve, even though Dr. Irshad mentioned his technique of trimming the valve, I really find they encapsulate and fibrose quite quickly. So within a week or 2 or 3, you may have great pressure, but you're going to be back to adding medications or cyclodestructive procedures. The next B is below. If you're going inferiorly, infranasal implants, Ahmed valve has higher rate of exposure and cosmesis issues. So with inferior location, you see this picture here with a tenon cyst, go with a Baerveldt. And if you want below target of 15, low teens, this is where the Baerveldt long-term is shown to have better results. And we show those two studies. So again, priming the implant, you've all been to the earlier lectures, so we'll just move forward here. With the Baerveldt, what's important, after flushing it, you have to occlude the implant. You cannot just put the implant without manipulating the tube. So it has to be occluded and even stented. We use 2 sutures, watertight. If you're concerned about hypotony, you may use an intraluminal suture for long term, so you can actually occlude the tube with a nylon or Prolene suture, and you can open up the device 2, 3, 4 months later once you're comfortable that there's a capsule developed. Again, these are just showing either a 5.0 nylon or Prolene or a 3.0 Supermid in the lumen. And then you occlude it with a 6.0 or 7.0 Vicryl, 6.0 typically in children, and then an 8.0 or 9.0 nylon to keep it occluded if you have a high-risk patient that you're worried about hypotony if it opens up in 5 to 6 weeks. Dr. Jadan and I were talking about a procedure when the Multino was very popular. They would even occlude it in the anterior chamber with a Prolene suture, and you can use an argon laser later to open up the tube. And here's the appearance of what the Baerveldt should be immediately post-op. See this white area? That's the ridge. If you see the ridge, that means there's no flow. You have a good scenario. So I'm just going to finish up with a clinical case. 14-year-old Saudi female, bilateral scleral buckles, inferior PI, aphakic, retinal detachment, pressure 4839, 0.9 plus cups, pretty much an average K-cash referral in the glaucoma division. So you see the buckle here. In this video, I'm just going to go through a little quickly. But first, Ahmed or Baerveldt? Well, we said inferior implant because of oil rising, so that's a B. The buckle, so another vote for a B. Dark skin patient, B. And then altered ciliary body, an A. So for the most part, the Baerveldt seems to be what we're leaning towards. So the video here is really fast motion because I've only got 10 minutes and I've probably got about 30 seconds before I get booted here. So if you look here, typical peritomy. Computer's a little slow. You can see muscle hooks, the implant going in. We're suturing the implant to the buckle. There we see it occluded with the 9.0 nylon, and it's watertight. We're putting now the intraluminal suture under the conjunctiva. I'm just going to fast forward a little bit here. Now, Dr. Issam talked about the corneal patch graft. I mean, I've been using cornea for about 8 years, and cosmetically, for an inferior tube, young patient, it's really the way to go. Sclera is really a no-win situation if you're putting an inferior tube. So here you can see the cornea patch graft coming up, split thickness. It's coming. And you pretty much just fillet the cornea into two halves, and then you look at how clear it is. And we'll just move on because my battery's telling me we have to go. So again, here's the patient post-operatively. There's the buccal pre-op, and you look at the pictures here. Cosmetically, it's very, very nice results. And more important than the cosmesis, her pressures have been in the mid-teens. You can't really see the tube or the patch. I'm doing here with a pointer, with a circle. Here you can see the tube. It's cosmetically quite good. And again, pressures in the mid-teens on 1 or 2 drops a year out with oil in the eye. So in conclusion, choose your implant based on your target pressure and risk factors for encapsulation or risk factors for hypotony, as I mentioned in my algorithm. And I really want to make a strong statement that glaucoma specialists have to be familiar with both valved and non-valved implants. No implant can claim to be better than the other. You really have to customize your implant. And remember, in glaucoma, there's no one shoe fits all. Again, thank you for your time.
I wanted to be practical, so I have some cases that I had in my office I want to share with you. These are office-based glaucoma cases that are presented to me, and how they should be managed. So let's begin. So you have here a 57-year-old female who was referred from a refractive surgeon back in August. She had LASIK, she had no family history of glaucoma, she had a baseball trauma to the left eye and was stitched in place. Her pachymetry was on the thick side, 20/20 vision, good intraocular pressures, and gonioscopy, the angle was open. But there was some history about the trauma, so I obtained a visual field test, because trauma is a risk for glaucoma. And look at this. She has a visual field defect in the right eye in 2011. The left eye is okay. It's okay. We know that it may be that you have to repeat the visual field test to confirm, because the trauma was in the left eye, not in the right eye, but yet the right eye was showing a defect. And look at those nerves. How did it look to you? Good? Did the nerves look good to you? Do you see any abnormalities there? They look pretty good, don't they? They're good, about 0.2, 0.3. And even on the OCT, 95% of normal. But yet I said, let me repeat the visual field test. And lo and behold, look again. She has a defect in 2011 and 2012 in the non-traumatic eye, which is the right eye. And I still don't see anything. How do you explain this? Why, the take-home message for this case is knowing your anatomy. And this graph on the left is very important for you if you don't know already about it, that the pattern of the axons that go to the optic nerve, you must understand that if you want to understand visual field abnormalities. And I'm not going to give you a lecture on that, but understand that any defect or any damage to the axons temporally will result in a nasal field defect that respects the horizontal. And this abnormality in the right eye does not respect the horizontal. Something ajib about this, right? If you have any defect that's nasal, it can cross the horizontal because it projects temporally. So this somehow doesn't make sense. Although the fact that this is a normal looking fundus, overall the OCT is normal, the optic discs are normal. So this is a take-home message that you have to look beyond just what you're doing. And lo and behold, what do you see? You see a big scar. I thought it was beautiful for teaching for my residents. It's beautiful. That smack center ocular toxoplasmosis lesion actually bisects the temporal raphe, and that explains why you have an abnormality above and below. So if this patient's eye was not dilated, it would have been very hard to diagnose this because the optic nerve is normal, the macula is normal, the imaging is normal, but this is a take-home message. You have to look elsewhere. This patient has an abnormality and it's been stable for several years. So it's very important to understand that you have to sometimes think outside the box. Case number 2. This child came to me, and the mother says that my child is going blind. Well, I need to do something. My child has glaucoma. So when I was in St. Louis at WashU, I saw this 10-year-old Asian female. She was adopted, so we don't know if there's any family history of glaucoma. And she was on timolol. Think about it. You're a small child, 10 years old. She's on timolol 0.5% twice a day for 2 years, and the pressure was 26. Pressure was 26. And she actually got on her knees out of the exam chair in front of me on her knees and showed me how she puts the drop in. A 10-year-old child on a beta blocker, there's something wrong here. And on top of that, without the drops, her pressure wasn't much different at all. And that's another take-home lesson. I want you to just keep that in the back of your head, that with or without drops, her intraocular pressures are pretty much similar. Her gonioscopy was wide open, the angles were wide open, her vision was 20/20, and she had normal fundus examination, and the nerves were symmetrical. And so what do you want to do with this child? She comes in your office. What do you want to do? Thank you so much. Jazakallah khairan. Understand, this is 1998. Okay, we took out a pachymetry. Look at the pachymetry, 725 microns. My mentor, Dr. Michael Cass, wrote this up in the article. 725 microns. I don't know about Dr. Khaimi and Dr. Samir, but most patients who have very thick corneas, it's not uncommon in my practice when I put them on drops, I don't see much of a big drop in intraocular pressure because that drop has a long way to go, especially if it's above 600 microns. And I tell the patients, if they do have glaucoma, that you must close your eyes for at least about 5 minutes. At least 5 minutes. There's a paper out in 1984 by Dr. Zimmerman who showed that if you close the eyes for at least 5 minutes, it prevents 64% of that medication from being absorbed systemically, meaning that much more is available. And by closing the eyes, it allows the drop to be absorbed into the eyeball. So I tell my patients, it's not what you are taking, it's how you're taking it. So I tell all my patients, if you can, 5 minutes, you close the eyes. Not towards the nose, on the outer 1/3 of the lower lid. Because if you put it towards the nose, it goes to absorb right into the nasolacrimal duct and it's gone. So I tell them outer 1/3 and just close the eyes. You don't need to put your dirty fingernails here. I tell people pick their noses, God forbid. I say just wash your hands, put the drop in the outer 1/3 and close your eyes for 5 minutes, and that'll help the pressure come down. So that was a very important lesson for me. So her actual pressure was less than 20. So you need to take all this into consideration. The intraocular pressure, the visual fields, the optic nerve head imaging, looking at it clinically on the fundus, and pachymetry. And we know that those patients who have very thick corneas, but they have a high pressure, they have a very small risk of developing glaucoma in 5 years from the OAT study. So thick corneas may reflect a thicker scleral coat, and there's a suggestion that it might be, the optic nerve may be resistant, but this doesn't always hold true. I'll move on for the sake of time. Let's go to the next case. We're 5 minutes in here. So a child comes in, 8-year-old, adopted. Again, an adopted child. This is America. Most people, adopt their kids there. Beta again, S twice a day in both eyes for 1 year. Referred for what? An abnormal visual field test. He suffered suffocation at 3 months, and there's a question about brain trauma. No ocular trauma, though. Again, his vision was normal, his intraocular pressures were normal. He had thin pachymetry, but even with the thin pachymetry, his pressures are still in the teens. So that's not an issue here. So what do you want to do here when you see someone like this? And here is fields. He took these fields, they're abnormal. He's referred for referral, that I don't know what to do. I got him on, a beta blocker for a young child running around. It's really not fair. You're slowing the heart rate down. You can cause other issues of breathing, etc. What do you want to do with this child? Anybody? Sisters? What do you want to do for this child? He's over here for a referral. Speak up, folks. I can keep going, but I want you to get some interaction here. What do you want to do for this child? They're good. They're normal. Here are the nerves. They look good. Did it look glaucomatous to you? He has an abnormal visual field test and normal optic nerves. What do you want to do for this child? Follow up? MashaAllah, observe. Okay, that's good. What else do you want to do besides what do you want to do in follow-up? MRI scan? Wallahi, MRI scan? Anybody else? And there's no APD. There's no relative afferent pupillary defect. There's no pallor of the optic nerve. Anybody else? So what you want to do for this child is stop the beta blocker, and we basically discontinued, I followed him for 2 years. I repeated the visual field test. Wallahi, look, that's normal. What do children do all day? That's what my kids do. What do they do all day, the kids? They play Xbox, video games, right? So if you get beat the first time, what do you do the next time? You go beat up the boss, right? They play, they get better. It's a learning curve. That goes to show you that you don't treat the test, you treat the patient. You treat the patient. The nerve looks good, the pressure is good. There's nothing there to explain glaucoma. Why am I going to subject the child to a beta blocker? For 1 year he was on the medication. We're 8 minutes in. We'll keep going here, inshallah. So the take-home message here is that there's variability in testing, and it's, according to the OAT study, you want to at least get 3 consecutive visual fields like this patient over here that maintained the same scotoma over time. So if the initial visual field is abnormal, you want to consider whether it's variability or true visual field loss, and you want to confirm it versus progression by repeating the visual field test. You don't want to unnecessarily subject your patients on medications for the rest of their life, especially a small child. Do not treat the patient, don't treat the pressure or the test. That's my take-home lesson for you. So sometimes it's easy to detect change, sometimes it is not. So you need to have, think outside the box sometimes. So here's another patient who comes in, 47-year-old, white female, and she's on lots of medications. She has very advanced optic nerve damage. She doesn't want to have any surgery done. She refuses surgical intervention. Look at all the medications she's on. She's Tomoptic XC. She's on pilocarpine. She's on Xalotan. And if you look at her very carefully, she has the same thing that I showed yesterday, a patient with Sturge-Weber. She did a very good job with the makeup. You can see she's got hypertrophy of her lip on one side. She's got a megalocornea on the left side. You can see everything's just hypertrophic. It's a very good job at cosmetics. She went to a good, beautician. And if you look at her eye, she has a bit of megalocornea on that side. This is a normal right eye. This is her myotic left eye because of pilocarpine. But you can see she's got angry blood vessels here with the epicellular vasculature. And you can see Hobbs striae. But why am I showing you this? Because I want to show you right here. Look how terrible her visual field loss is. It's terrible. She's going to go blind, but she doesn't want surgery. But look at this here. I've been watching her now for almost, more than a year. Her bad eye, the left eye, always is in the 20s. Always 20, 22, 25, and all these meds. And suddenly she came one day, and her pressure was about the mid to low teens. I said, something doesn't make sense here. And again, I repeated that her pressures the following year, again, they were low. So what do you think is an explanation as to why the pressure may go down in a female? I want to get some input. Why would the pressure go down? She hasn't changed any medications. She didn't have any surgery. Why is her pressure suddenly down now on the same regimen? Any guesses? Hormonal change? Well, she might be pregnant. That can cause the pressure to go down. What's another explanation for the pressure going down? Huh? Choroidal mass? I'm sorry. I didn't understand it. How about compliance, right? She's taking her medications properly. Maybe she wasn't taking her medication. Now she's taking it, right? So compliance is one explanation. Maybe it could be hormonal from her, if she's expecting or, she's pregnant. But that was very, very curious. So I confronted her. I said, what's going on over here? Why is it your pressure is so low? And I've been seeing you for how many years now? Almost 3 years. You know what she said? She said 45 minutes before she came to my thing, she smoked marijuana. She smoked marijuana before she came to my office. And so that got me thinking. I said, I want to check this out. And I looked at this thing. I found a publication in JAMA in 1971. And you can see here, all of these subjects, there are 11. And I can assure you, wallahi, none of the patients dropped out of the study. None of them dropped out of the study. And they all smoked a nice, ice-cooled water pipe, 2 grams smoked. And there was a drop of pressure of 30% to 60 to 65%. Look at the drop in pressure here in this JAMA study, 45% from the subject number 11. So this person was just smoking it up because she's stressed out. But the problem with marijuana, as you know, is that it's a highly lipid-soluble drug. Although it lowers the pressure, it does't have just pressure-lowering effects. We don't understand the actual mechanism of it. It's interesting that Eli Lilly, a company, tried syrup, it tried pills, it tried drops. None of it worked. The only one that lowered the pressure was smoking it. And
Shaquille, did you give her fatwa to smoke marijuana or no fatwa?
Ask the sheikh.
No fatwa, okay.
Sheikh, the sheikh in the back, mashallah. We got a fatwa back there. So the duration of the marijuana is about 3 to 3.5 hours. So you have to smoke it every 3 hours. You won't be able to function. You just be very happy all day and do nothing, lazy, Kaslano, right? So it reduces the blood pressure. It can actually compromise the blood flow. And here's one woman who was an advocate for marijuana. She has a 1 month supply of marijuana joints in her pot there. But of course, we don't think about marijuana much because we have better drugs now. It has long-term effects of pulmonary toxicity, emphysema, lung changes. And the reason why there was an interest back in the 70s, understand the time of this. We had pilocarpine, a miserable drug. We had epinephrine-based drugs, right? Terrible drugs, beta blockers. We didn't have much available, but now we have prostaglandins, alpha-2 agonists, much safer drugs. So the take-home message is take a good history. Sometimes you just go in the routine of checking pressure. If you see something out of the abnormal, I confronted her in a very nice way. I said, what's going on with you? How come your pressure is down like this every time you come? I'm sorry, doctor, but before I came to your office, about an hour and a half, I smoked marijuana. So don't underestimate your patient. She's 47-year-old. She's a woman. Hey, anything's possible, right? I had another woman come in like this. Acute presentation. Chemosis, 360 degrees. She's in a lot of pain. She's literally blind. She can't see. And she was crying. So anybody want to comment about a bilateral presentation of chemosis and one of them having mid-dilated pupil? She came to my office. She's about 57 years old. What would come to your mind? Of pressures about 50 in both eyes, periorbital chemosis, perilumbal chemosis, and one pupil is a little bit dilated. What would make you think that? She's 57, so she's not in that age group of an acute angle closure, which would be typically seen in the sixth or seventh decade of life. Any ideas here? But why bilateral? That's the take-home message here. Why bilateral? What does that make you think when you see something bilateral? What should come to your mind when you see something bilateral? Bilateral glaucoma. What does that make you think? What category?
Headaches.
I'm sorry? Systemic, right? Systemic. So I took her history. I admitted her to the hospital because she couldn't see. She was hand motion. She was crying. She said she wanted to go blind. She basically had a very shallow chamber. Okay? She was really in a lot of pain. She basically had an acute presentation, even if she was 22, because you don't get acute angle closure in someone who is 20, 30 years old. If you see someone like that bilateral, think medication, drug history. And I looked at this. There's too many to talk about over here. Every drug known to man has some side effects or contraindications for glaucoma. And for the sake of time, I looked at actual literature for 40 years, and I've identified on PubMed 136 cases in 40 years. And the majority were bilateral, anti-epileptic, antidepressants, sulfonamide drugs. They were up the most and top. 93 cases of topiramate. So it's always important to take a good history. Someone comes in, and as you know, the treatment for this is not doing laser iridotomy. You have to stop the drug. So I admitted her to the hospital. I watched her over 24 to 48 hours. It resolved, and her vision came back. So that's important. She was on topiramate, which is a drug for weight loss. It's an anti-seizure drug. It's used for management of migraine and so forth. So you need to take a good history, right? Sometimes your medications for cold and flu, your phenylephrine, right? They can cause mydriasis. You need to take a good history. And so it's always also an off-label use for weight loss, and she was using it for weight loss, and she did better. So the treatment here is basically stop the medication and just temporize her and get this taken care of. Basically, it's a superciliary effusion, and there is an anti-rotation of the ciliary body that basically closes the angle. And so therefore, someone like this, you have to especially think if they're under 40 years of age. You don't get bilateral angle closure under 40, right? You got to think drug, you got to think systemic. And so the visual field must correlate with the neurofibrillary anatomy. These are my summary points. The pachymetry, you must do that in your patient, okay, if you haven't done it. Make sure your visual field loss is reproducible. Make sure you present a good history like this patient with marijuana. And bilateral angle closure under a patient under age of 40, always think systemic. Take a good history and find out what drugs they're on. We have about 3.5 minutes left. Last quick case. This patient came to me, 54-year-old female with no family history of glaucoma, type 2 diabetes, and her pressures are always within normal. When the doctor sent her to me, look at this summary here. This is spanning almost 3 years now. Look at her pressures, 29, 30, 24, 28. The pressures are always in the high 20s to low 30s. It didn't matter what drugs they gave her, whether it's Xalotan, Alphagan, the doctor tried everything. And so the referral basically said, why is she having such an excellent drop in pressure in the Medicaid, but suddenly the pressure goes right up again? Why does she become intolerant? She has a cup to disc that's 0.4, which is normal, and her visual fields are normal. So what's going on over here? Let's take a look at this woman. Look, she basically has red eyes since taking drops. No kidding. That's probably the benzalcornium chloride causing the red eyes. But she's got 20/20 vision. She's a slightly thin pachymetry. She is myopic. Her pressures were 33 and 41 when I saw her in the office. That's very high. Okay? But the angles are open. But look at her. This is the patient. Okay? Her right eye. Look at her left eye. This angry-looking eyes, mostly because she's on all those glaucoma medications. Look how protruding this eyeball is. There's some nice photographs by a photography department, and this is the appearance of her nerves. Her neuroptic nerves are normal. They're absolutely normal. She has a normal RNFL-OCT, essentially. And this is the resident who checked the pressure on the patient. The resident got 33 in the right eye and 41 in the left eye. When I checked that patient, literally about 45 minutes later, I got a completely different number. How could that be possible? This is 45, I got 33 to 18, 41 to 19. How can I get a 50% drop in 50 minutes? How is this possible? She has thyroid eye disease. So keep going. What does that mean? Shukran, jazakallah khair. So basically, when you ask the patient to look straight during applanation, she's lifting her eyeball up against her inferior rectus muscle. You understand, right? The first muscle to get involved in thyroid disease is the inferior rectus muscle, right? So when you tell her, look straight ahead, that's not her normal gaze. And look at these pictures over here. This is her normal gaze. Now, this is the way it is. The bottom of the limbus is right along the inferior lid margin. You see that very nicely. But look what happens over here now. When she looks up, look how abnormal that is. I took a side picture. She's really straightening on the inferior rectus muscle, and that pressure of 19 is now 40 and 43. Otherwise, you can go crazy and do trabeculectomy on her, right? Oh, I'm sorry, Barvelt. I forgot. Barvelt. Do the Barvelt on her. All right, look at this. Really bad shape. Look how she is when you ask her to look straight ahead, and then when I ask her to move her chin forward, on the chin rest, look how that eye looks. That pressure up there is 33. That pressure down in the same eye is 18. In the same pressure check in the office. And to my best of my knowledge, I'm not aware of any correlation. My colleagues can tell me here a correlation between thyroid eye disease and glaucoma. I'm not aware of it. Okay, essentially, I looked it up. I did not see any association of hypo or hyperthyroidism with development of open-angle glaucoma from the ophthalmology journals, including New England Journal of Medicine. So have the patient look straight ahead. I mean, it's not normal for that patient. Make sure they're looking in the normal position. Maybe she's got the Valsalva holding her breath, and of course, Bob Rich from New York Eye and Ear has talked about the tight neckties, and that's a totally different ballgame. But I hope this is beneficial. Shukran, jazakallah khair. Assalamu alaikum.